Next is the college lecture. Now we have a series of lectures in association with the other colleges to introduce the speaker. I invite Dr. Ranjit Piris, the Senior Consultant in Gastroenterology at National Hospital.
Good afternoon. On behalf of the Sri Lanka Society of Gastroenterology, I would like to welcome you all for this college lecture organized by Ceylon College of Physicians, which is delivered by Dr. Eranga Thalagala. It's my pleasure to introduce Dr. Eranga Thalagala, who obtained his MD Medicine in 2016, and he was a Senior Registrar in Gastroenterology from 2016 to 2019 in National Hospital as well as in Colombo North Teaching Hospital. Then he pursued his overseas training in Cambridge University Hospital in UK. Currently, Dr. Thalagala is working as a consultant gastroenterologist in General Hospital, Matale.
Thank you very much for that kind introduction. And first of all, I would like to thank the Ceylon College of Physicians and Sri Lankan Society of Gastroenterology for giving me this valuable opportunity. So today I am going to discuss about management of Helicobacter pylori in 2022. So I'll be going over these topics during the next 20 minutes or so. So why did I choose this topic? So this is one of the most prevalent infections worldwide, if not the most commonest. It is estimated that more than half of the world population is infected with this infection, and this is associated with considerable morbidity and mortality due to peptic ulcer disease and gastric cancer. This was first described in 1983 in association with chronic gastritis, and the identification that most of the duodenal ulcers caused by H. pylori and about 2/3 of gastric ulcers was caused by H. pylori infection was a Nobel Prize winning medical breakthrough. And since 1994, WHO has classified H. pylori as a top carcinogen. So this causes chronic active gastritis in all colonized subjects, and this persists for the lifetime unless we treat and eradicate it, and in a few special occasions. And this is associated with several gastropathies such as chronic gastritis, peptic ulcer disease, mucosa-associated lymphoid tissue lymphoma, and gastric cancer. So this is a picture of a peptic ulcer, and this is an endoscopic picture of a gastric cancer. So H. pylori eradication cures gastritis and can alter the progression to long-term complications or recurrence of disease. So it is very important to we diagnose this disease and prevent the long-term complication. Specifically, if we can detect a patient before they develop precancerous histological status, we can prevent gastric cancer. Even after developing precancerous histological changes, by treating, we can reduce the risk of progression to cancer. And although we know this disease for almost 4 decades, the optimal clinical management and treatment pathways remain unsettled. And even the existing guidelines are evolving with changing antimicrobial resistance patterns. And it is a major challenge for guidelines to achieve relevance across a wide variety of population. For an example, currently we depend on the Western guidelines, but obviously the prevalence and the disease phenotypes and the antimicrobial resistance patterns are different from those countries when compared to our country, and also obviously we have different resources. So This was a nice meta-analysis done by Ford et al. And in this meta-analysis, they have assessed the ulcer recurrence rates according to treatment for H. pylori infection. So at the baseline, they had peptic ulcer disease, either duodenal ulcers or gastric ulcers, and also they had active H. pylori infection. So they have one group was treated for the infection and other was not. And after 1 year, the ulcer recurrence rates were significantly lower in the treated group, both in duodenal ulcers and in gastric ulcers. And also the number needed to treat was very low, which is good in both categories. For duodenal ulcers, by treating 2 patients, we can prevent occurrence of 1 duodenal ulcer within 1 year. For gastric ulcers, it was 3. This was a meta-analysis which showed the association between the H. pylori and the gastric cancer, and this meta-analysis was based on 7 RCTs conducted in Asia, and there were 8,323 healthy people with positive H. pylori, and those people were randomized to the active treatment group and to the placebo group. The treatment of infection has led to a reduced incidence of gastric cancer and reduced mortality from gastric cancer. And this is another retrospective cohort study which showed the association between H. pylori and gastric cancer. And this was conducted on at USA on veterans. There were more than 370 thousand veterans, and around 10% of them were infected. And after mean follow-up of 7.4 years, around 1 in 200 developed gastric cancer, and successful confirmed eradication was associated with 76% reduction in risk of gastric cancer. So H. pylori is linked with several extra-intestinal conditions. So various diseases were proposed. So stroke, coronary artery disease, hypertension, hypothyroidism, and Alzheimer's disease. But only except for 2 conditions, the association is not strong, and there is no strong evidence to suggest association. But unexplained iron deficiency with or without anemia and adult idiopathic thrombocytopenic purpura has modest evidence to suggest there is an association. This is another interesting study by Stasi et al. This was a systematic review in which they have identified 696 adult patients with ITP treated for, and they were treated for H. pylori infection. 43% had complete response and 50% had partial response. In this study, interestingly, around 38% of the patient never had any treatment for ITP before the commencement of H. pylori eradication. And because of these results from the various studies, the American Society of Hematology recommends screening for H. pylori infection should be considered in adults with ITP in whom eradication therapy would be used if testing is positive. So epidemiology. So in 70 to 90% of the people in developing countries are colonized, but in the developed countries, prevalence is much more less. For an example, in United States, it is around 35%. And in our context, we don't know the exact prevalence. There were very limited number of studies done in our country. According to one study, the prevalence was 9.7%. Whereas in the other study it was 70%. There's a wide variability. I think actually these were not true prevalence studies. These were clinical audits done on specific clinical subsets of patients, and they have used different methods to diagnose H. pylori. For an example, one study used histology, other one used the PCR from the histology samples. So I think and also the biopsy protocols may be varied from center to center. So I think those reason is the underlying cause for this wide variability of prevalence in our country. So this is a world map showing the prevalence of the H. pylori, and we can clearly see that most of the developed countries have developing countries have a high prevalence, like Pakistan, India, and the major exceptions are Japan and China and South Korea. Although they are developed countries, their prevalence is again high. So the prevalence of H. pylori is reflected by degree of socioeconomic development. To be more precise, it is the socioeconomic status during the childhood, because this infection is usually acquired during the childhood. And the basic resources such as access to clean water, healthcare, and modern sanitization plays an important role in H. pylori prevalence. And so if we can improve the socioeconomic status, we can't interrupt the transmission at the community level. So it is thought that this infection is transmitted from person to person or via a common infected source. And transmission is thought to occur through gastro-oral, oral-oral, or fecal-oral routes. So this gastro-oral means they have isolated H. pylori from vomitus. And the predominant mode of transmission is unknown. A few words about pathogenesis. This is a gram-negative spiral flagellated microaerophilic bacterium. And H. pylori uses a flagella-mediated motility for movements towards the stomach epithelial cells and to penetrate the mucous lining. And it lives near the surface of the human gastric mucosa, and they have evolved so many mechanisms to avoid bactericidal acid in the gastric lumen. So one particular mechanism they use, they have urease. So they can catalyze the hydrolysis of urea to ammonium and carbon dioxide, which will in turn increase the pH around their their habitats. So the other virulence and colonization factors are they have multiple additions molecule, and they have some secretory proteins such as VAC-A and CAG-A. As I mentioned earlier, this infection is usually acquired in the childhood, and chronic gastritis will develop in virtually all persistently colonized persons, but luckily 80 to 90% of people will never have symptoms. But this has a very high prevalence, that about more than 4 billion people are infected. The minority patients, the 10 to 20% people, when we take as a number, there's a large number of suffering from the symptoms due to H. pylori. The clinical cause is highly variable and depends on bacterial and host factors. And interestingly, this infection can cause, in some people, they cause high acid output, in some they cause low acid output, in some they cause normal acid output. So in patients with higher acid output are likely to have antral predominant gastritis, and in antral predominant gastritis patients, they are more prone to develop duodenal ulcers. And patients with lower acid output are more likely to have gastritis in the body of the stomach, and they are predisposed to gastric ulcer. And minority of patients having corpus predominant gastritis can initiate a sequence of events that in rare cases leads to gastric carcinoma. And also in this category, they are predisposed to mucosa-associated lymphoma as well. So again, the same thing. So there are three main phenotypes. Majority of patients will develop a simple gastritis phenotype, and some will develop duodenal ulcer phenotype. About around 1% of the infected subjects will develop gastric cancer type phenotype. So disease infection outcome will depend on the host genetic factors, bacterial virulence factors, and also environmental factors. This is the natural history of the H. pylori infection. So we should try to catch or detect the infection in this stage to prevent the gastric cancer before developing precancerous histological changes such as atrophic gastritis and intestinal metaplasia. So let's move on to investigations. So most of the guidelines recommend test and treat strategy rather than blind empirical treatment. Patients with low risk for complications, we can go for non-endoscopic investigations or non-invasive investigations. Patients with high risk for complications or alarm symptoms, endoscopic investigations are needed. So whether we can go for empirical therapy in a low resource region like our country, especially considering current economic crisis, is a matter for a discussion. The problem with empirical therapy is we will be treating, giving antibiotics for unnecessary group of unnecessary people. So, and it will further give rise to the antibiotic resistance, and also they can have the side effects or the adverse effects from those medication unnecessarily. So this is a bit of a crowded slide. Sorry about that. First I will explain in whom we can do non-invasive or non-endoscopic investigations. Young patients with uninvestigated dyspepsia without alarm symptoms, we can go for non-invasive screening. And also with adults with ITP and unexplained iron deficiency anemia, we can go for non-invasive screening first. And this is very interesting. Most of the guideline recommends to test and treat before starting NSAIDs. Chronic, if we are planning to start chronic NSAIDs therapy for a longer duration, most of the guidelines advise to test for H. pylori infection. It was a strong recommendation with moderate quality evidence. And patients who are already on chronic NSAID therapy, the benefit is unclear. And for the patients who are on chronic use of low dose aspirin, again they recommend to test and treat for H. pylori, because both NSAIDs and aspirin are associated with if they have H. pylori infection as well, they are more prone to develop peptic ulcer disease and its complications such as bleeding and perforation. And whom we should go for more invasive or endoscopic investigations, those are people who are having active peptic ulcer disease, prior history of peptic ulcer disease, and patient who had low-grade mold lymphoma or previous history of endoscopic resection of early gastric cancer. We have to go for invasive screening. And patients who are more than 60 years and who are having uninvestigated dyspepsia, we should go, or patients who are having alarm features, we should go for more invasive screening. So the alarm features are dysphagia, unintentional weight loss, evidence of upper GI bleeding, maybe melena, maybe hematemesis, maybe coffee ground vomiting. Then we should go for more invasive test. If positive, we have to treat. And after treatment, we should test for eradication. So there are several non-endoscopic investigations. The worldwide mostly common used test is urea breath test. Unfortunately, this is not available in our country. So in this urea breath test, we give labeled urea which contain either carbon 13 or carbon 14. Carbon 13 is a radioactive, so it is not advocated for pregnant mothers or for children. So in the presence of H. pylori, they will have urease enzyme, and this will be catalyzed, hydrolyzed into the ammonium and carbon dioxide, and this carbon dioxide will be absorbed into the bloodstream, and it will be exhaled with the breath. And this labeled, by using the analyzers, we can measure the amount of labeled carbon dioxide. So although we don't have urea breath test in our country, the stool antigen test is having a almost similar sensitivity, around 95%. So this is available in the private sector. And the other non-endoscopic investigation is serology. In this, we measure the IgG levels. So it is obvious that we can't use this in the clinical settings because we can't identify the acute infection from the past infection. So we can use serology for seroprevalence studies, but not in the acute clinical setting. So there are several endoscopic investigations. The most commonly used one is the rapid urease test or the CLO test. Again, we use the principle of presence of urease enzyme. So in this, there's a slide which contain a media containing urea and indicator like phenol red. So we take biopsies during our endoscopy, usually 2 biopsies, one from the antrum and one from the gastric body, and then we put those samples into that slide. If the H. pylori is present, there will be urease enzyme, and then it will produce ammonium, and it will make the pH high, then there will be a color change from usually from yellow to red. And we can take biopsies during our endoscopy for routine H&E. Most of the time routine H&E staining is adequate, but at times we may have to go for immunohistochemistry. And PCR is mainly for the research purposes. And culture and ABST, actually I mentioned that this is a microaerophilic bacterium, therefore it needs specific transport media and specific skills and specific laboratory test. So it is, the culturing is not easy, but in case of treatment failure, we might have to go for culture and ABST. So if we are planning to do a urea breath test, rapid urease test or stool antigen, we should stop antibiotics and bismuth containing compounds at least 4 weeks before testing, and we should stop PPI before 2 weeks. Some guidelines, according to some guidelines, we can use H2 receptor antagonists such as ranitidine and famotidine up to about 48 hours, but some guidelines advise against that, and they recommend stopping H2 receptor antagonists at least for 2 weeks as well. So even for histology, it is better we can stop antibiotics 4 weeks before and PPI for at least 2 weeks. So after treatment, we should do for test for eradication. We can use 2 tests, again the stool antigen and the urea breath test. So in our country, so we are left with only one option, so we can use stool antigen if the patient can afford. When last time I checked, this stool antigen cost around 2,000 rupees. So most of the testing of eradication is performed 4 to 6 weeks after the stopping of the therapy. And again, I am highlighting there's no place for serology to look for eradication. So that next we'll move on to treatment. We have first line therapies and salvage therapies. So whom to treat? Any patients who test positive for H. pylori should be treated. So before there are various regimes. Before selecting one regime, there are some things to consider. So we should assess the patient's recent history of macrolide and quinolone exposure. So I said that this infection was usually acquired during childhood and lives in the stomach. So this bug is basically exposed to all the antibiotics we have ingested from our childhood. And also most of the regimes contain amoxicillin. Then therefore we should consider the presence and type of penicillin allergy. And also we should consider the resistance to clarithromycin and levofloxacin in the geographical area. The treatment regime must always include a proton pump inhibitor and a combination of 2 to 3 antibiotics for at least 10 to 14 days. We should include a proton pump inhibitor because at lower pHs, H. pylori is in a coccoid form and which confers antibiotic resistance. So with PPIs, the pH increases to 6 to 7 and they convert to this spiral form, and that spiral form is more susceptible for antibiotics. So these are the available options. I will be going through one by one. The clarithromycin triple therapy is the most commonest treatment regime worldwide. It consists of PPI, clarithromycin, and amoxicillin. We can use metronidazole if allergy to amoxicillin. And treatment should last for 14 days, not 7 days. And success of clarithromycin triple therapy depends on the rate of the clarithromycin resistance. But if we don't know the local clarithromycin resistance rate, or if the resistance rates are more than 15%, better to avoid clarithromycin triple therapy. So for those kind of people, we can go for bismuth quadruple therapy. Unfortunately, we don't have bismuth in our country. So what we can use is this concomitant therapy, which includes a PPI, amoxicillin, clarithromycin, and a nitrimidazole. Could be tinidazole or metronidazole, and should be given together for 3 to 10 days. But in our setting, I think better go for at least 10 days. So the concomitant therapy has a higher intention to treat cure rate than clarithromycin triple therapy with a cure rate of 90%, whereas in clarithromycin based triple therapy it is just 78%. So this is another treatment modality. It's a sequential therapy, a bit complicated for the patient. Initially we treat with PPI and amoxicillin for 5 days, followed by PPI, clarithromycin, and a nitroimidazole for additional 5 days. So the overall success rate for this sequential therapy is around 84%, and it is more successful than 7 days of clarithromycin based triple therapy, but only slightly better than 10 days of clarithromycin based triple therapy. And another treatment regime is hybrid therapy. So initially we treat 7 days with PPI and amoxicillin, and followed by another 7 days of PPI, amoxicillin, clarithromycin, and nitrimidazole. And American College of Gastroenterology guidelines suggest hybrid therapy as an alternative to clarithromycin triple therapy. Again, this may be a bit complex for the patient. So we can use levofloxacin in various these regimes. We could use levofloxacin as an alternative to clarithromycin based triple therapy, but looking at our prescription pattern, we may have higher levofloxacin resistance rate compared to clarithromycin rate. So in treatment failure, so what is treatment failure? Treatment failure is defined as unsuccessful eradication of H. pylori as indicated by non-serological testing. According to the US data, around 20 to 30% patient treated for initial episode, they failed the first line therapy. In some countries, eradication rate has fallen from 50 to 75% in some countries. So for those kind of people, we should use salvage therapies. This is a flow chart we can follow to decide what we can use as salvage therapies. But the basic principle is we should avoid using the same antibiotics, and the selection should be based on recent exposure to antibiotics and the local antimicrobial resistance data. So we can use these various regimes if we haven't used them as our first line treatment. And one special consideration is after about 2 failures, we can use rifabutin triple regime consisting of a PPI, amoxicillin, and rifabutin for 10 days. And if a patient received a first line treatment containing clarithromycin bismuth therapy, levofloxacin is the recommended salvage treatment option, and if someone is going for a empirical treatment, never ever use levofloxacin, because we know that levofloxacin is a second-line anti-TB drug. And also the rifabutin should be prescribed only by the specialist, because again rifabutin is a drug we use in multi-drug resistant TB. And one slide about novel therapies. There are several emergent therapies. Of all of that, I would like to mention this vonoprazan. It is an oral anti-secretory drug, and it is more potent and long-acting acid suppression agent than traditional PPIs. It improves antibiotic efficacy, and it competes with the potassium to reversibly block the action of hydrogen potassium ATPase. And it is more acid stable and is less impaired by the CYP2C19 enzymes in the liver. And it has a very high potency. The potency is 350 times that of traditional PPIs. So in summary, the H. pylori infection is a common worldwide infection associated with considerable morbidity and mortality, and it is associated with gastroduodenal and extra-intestinal pathologies, and the prompt diagnosis and treatment can cure or prevent clinical consequences. Rising antimicrobial resistance rate is a major challenge, and in our settings, lack of data regarding prevalence, antimicrobial resistant patterns, and lack of resources are major challenge in our setting. And these are my references, and thank you, and I would like to take any questions if there are any.
Thank you, Eranga, for excellent presentation. Now, this is open for questions and comments from the audience.
Although there are no, I don't think there are any recent seroprevalence studies, but overall, Ranjit might know better, but compared to nearly 20 years ago, 30 years ago, I find the incidence of peptic and gastric ulcers are much less now.
Yes, sir.
Very much less. You hardly see duodenal ulcers now. So there must be a drop in prevalence.
Actually, sir, that 70% prevalence was done in before 2010, around 2003 or 2, but the 7% prevalence, that study was done in 2011. So you are correct, sir. The prevalence is decreasing even in our country, sir.
Yeah, it's very uncommon now to get duodenal ulcer.
Our antibiotic policies also may be contributing, because most of the time the general physicians, GPs, they give antibiotics. Metronidazole, amoxicillin is a very commonly used antibiotic, which is involved in triple therapy.
And also there are some commercially available kits. So sometimes we have seen that GPs prescribe those empirically.
So what we see is not a true representative of the prevalence of H. pylori in our community. Even though we check for H. pylori during our endoscopy, suspected ones, most of the time we get negative results. It's a very important point. Now we see quite a few moldivian patients where they come to Sri Lanka for treatment, where the antibiotic policy is very strict. Their positivity is very much higher than our population.
Any more questions? Yeah. In the absence of any other question, may I invite Dr. Ranjit Peris to hand over the letter of appreciation and the certificate to Dr. Eranga Thalagala. And thank you very much for the participation, and we'll meet in a month's time for another series of lectures. Thank you.